So I think the work that you've done with the home care pharmacists in care homes about medicines optimisation is really good practice, because often, as we know, older people often on polypharmacy and a lot of medicines are redundant. And I just thought a really excellent strand of work that you did there. So thank you for that.
Any more points, please? Thank you. Right, we've been asked to note and support the contents of the report. Are we happy to do so? Okay, super. Thank you for coming to speaking to us this evening, and good luck with your work. Moving on, item 6, the Trafford Mental Health Transformation Update.
I can't support that we're removing prescriptions for low-income families and people on universal credit who need those things prescribing to them. So no, I'm not supporting it.
I would be with the other councillor on that as well.
Can we suggest then that we support the report apart from what has been raised in terms of the celiac and the gluten-free products, and that we ask, they're still here, yes, and that we ask them to look again at that, because I think there's some concern raised by the committee that some provision needs to be made for those people. And would you mind reporting back to the next meeting, which is in March?
Yes, absolutely. We can report back because Lee says it's an ongoing piece of implementation. We are taking the themes and the comments that we're getting back, particularly around low-income families, so I'll ensure that that's presented back to next committee. Thank you.
Thank you. So can we support it with that exception? Thank you. Super.
Yes, with that exception.
From them again. Item 6, Mental Health Transformation Update.
Okay, I've introduced myself already, so thank you again. So you have again received a paper around the Trafford Mental Health Transformation Programme, and in particular the implementation of the Primary Care Mental Health and Wellbeing Service. Committee have received previous updates on the wider 5-year forward view. Am I getting some feedback? Shall I use your? That better? Yeah, okay, thank you. So yes, committee have received previous updates on the wider 5-year forward view and priorities for mental health. There was a recent update at Health and Wellbeing Board on those 5-year forward view priorities. We had a mental health partnership meeting this week where we talked about the Trafford local mental health strategy development. And I also presented at Children's Scrutiny last week on the children's mental health agenda. So what we thought would be helpful to do is focus the discussion and the paper tonight on a particular transformation scheme update. The Trafford Primary Care Mental Health and Wellbeing Service was identified as a really clear priority in our Transformation Fund bid, which a lot of you will recall from a couple of years ago, and an absolute priority in terms of our neighbourhood development in Trafford. This was based on feedback from general practitioners, feedback from patients, and feedback from other partners in the system about the need to really bridge the gap between the currently commissioned IAP services and psychological wellbeing services and the more complex patients going into secondary care. The feedback that we were getting is that people were really being bounced around the system, in touch with many, many agencies and not getting the support that they needed or deserved. And so the concept of a primary care mental health and wellbeing service was very much developed in partnership with all of those agencies and with patients to support existing performance targets around IAPT, but also to really innovate and have a different kind of a model in Trafford. What's really been good to see over the last couple of weeks is with the publication of the NHS 10-year plan. It very much talks about an integrated primary care, neighbourhood and mental health model. So we feel like we're slightly ahead of the curve really in terms of our local plans. I won't go through all the paper in much detail, but in terms of the kind of key objectives of the service, these are to improve the health and wellbeing of Trafford citizens experiencing mental health difficulties, to improve the quality of and access to mental health services, care and support for Trafford citizens experiencing mental health difficulties, to improve the physical health of Trafford citizens experiencing mental health difficulties, and in doing so narrow the gap in life expectancy, really clear link between long-term condition management and mental health, which again our health professionals are feeding back to us, and to improve the mental health support available to Trafford citizens with those diagnosed long-term conditions. In terms of the need and the link to the Joint Strategic Needs Assessment, data from 2018 shows that in Trafford, you're up to 5 times more likely to die early if you have a serious mental illness. And I know it's a really clear public health priority and health and wellbeing board priority. From a commissioning perspective, the model was very much designed in a co-production fashion with our partners. And even though we don't commission the service through a local care alliance or through Trafford's local care alliance, the methodology of working with system partners to really deliver the model through a lead provider arrangement is a principle that we've worked towards. And I'll hand over to John, who will introduce himself, who will talk to you a little bit more about how we've done that.
Thank you. My name's John Walker. I'm the Associate Director of Operations at Greater Manchester Mental Health. And Greater Manchester Mental Health will be the lead provider for this model. We hope to be operational by the 1st of April, and certainly we aim to have a phased approach. That is, of course, recruitment, provided that recruitment goes to plan, which we are actually seeing a real interest in working within this team. So at the core of the model, the primary care model, we have consultant psychiatrists, mental health practitioners and peer navigators. And as you can see within that model, it's wrapped around by social prescribing and volunteering, which are key aspects of what we want to deliver. It's a fantastic opportunity, I think, to do things very differently and work with our voluntary care sector organisations. There's a really rich voluntary care sector in Trafford, and we want to plug into that. And as the lead provider, want to make sure we use those resources that really are available. So the team will span the 4 neighbourhoods, be co-located in GP practices and in hubs, and stick to a care navigation model, which will promote quick and easy access to social prescribing. We really want to make sure that we connect and we reach out to those community services. Some of the key outcomes for the model are reducing the demand across the health and social care sector, and actually improving outcomes for service users who are often seen, I think, as difficult to engage and really do move around different agencies and really struggle to, I think, to be fully engaged. So some of the things that we think the service will be able to deliver are we will be able to work with those GPs and provide support and advice, and for them to work with us really in partnership around supporting these individuals. We will be able to support neighbourhood teams, and we'll be able to deliver mental health training and sort of engage the wider services in terms of mental health. The neighbourhood teams will link with social prescribing and volunteering, provide high-intensity psychological therapy interventions, and work with those patients who might sometimes otherwise end up at A&E departments. I think we want to really engage the wider community. Important to have really core and key partnerships. So as you can see, there are many bringing together lots of partners around NHS Trafford, Trafford Public Health, the Local Care Alliance, GPs, and many others. In terms of implementation and how we're moving really well, working in partnership with the CCG and with the voluntary care sector in terms of trying to ensure that we have a really robust offer to start with on the 1st of April. We do expect a phased implementation because recruitment is ongoing. We're attracting a lot of interest, and as soon as we bring people in, we'll be growing the model. It's really important, I think, that we're in the process of looking at our KPIs and what those real quality measures are that we need to pull out, and it's really important that what we deliver is a sustainable model that will really make a difference in Trafford and for those people, as I say, who are very difficult to engage. And that's it. Sorry, I saw your hand up. I think you can ask a question.
Well, can we take questions when you finish, please?
So in summary, I think it's a really exciting opportunity for us to work in partnership and work with some of those service users or those people within the community who often are seen as difficult and who will be provided with a fantastic standard of care.
Councillor Haddad.
It sounds a real wonderful concept with great aspirations, and reading it, I felt that. I did feel though that it feels like there's a disconnect between the aspiration and the concept and the detail of how it's going to actually be rolled out. And it's starting in April, and I felt like, we didn't really understand how that is going to, the detail of how it's going to be rolled out. And the care navigation model, I don't, how is that going to work in practice? And recruitment of staff, what type of staff?
We've got mental health practitioners and peer navigators. The idea, I think, is to make sure that this is a hands-on model, which we're working locally with those who use the services. And I think the plan is that a lot of models expect people to come to them, and this is a model that reaches out, and in terms of being able to reach right into the community and access communities and really work with those service users, help them, support them to appointments, to those things that we know that they find difficult, those difficult to motivate and reach service users who often, our services are built around people coming to us, and this is a model that reaches out and goes out to those service users. I think in terms of the what and the how, we're working through our model as we speak in terms of how we can do that within those local communities. There'll be mental health practitioners who are care coordinators also. Those peer navigators, we want them to be community-based. We want them to be part of the voluntary sector. We have a model within GMMH that we've used in terms of care navigators, and really those peer navigators will be voluntary care sector organisations. Within voluntary care sector organisations, they're already plugged into that local community, and the idea is that they will ensure that those service users, in terms of a social prescribing model, have an offer within the community that is sustainable and not reliant on other services. So I think it's to grow people's confidence and to grow a community offer as well in terms of what we can provide.
Yeah, sounds like an education program rather than what.
I can add to that if that's okay. So we've got a more detailed operating model, if that would be helpful, and we're more than happy to share that, which details much more about the clinical post. So it may be because the diagram's a little bit small on the page as well. We did have a bigger copy to project. So we've got clinical staff who will actually be based with GP practices in the neighbourhoods. So GPs will have access to clinical staff who will have a caseload of patients. We've got mental health nurse provision within our Trafford Coordination Centre, so there'll be a point of access back into the TCC as well. So happy to share that if, to you as an individual, if anybody else wants to see some more detail around the operating model. The care navigators, through the general practice 5-year forward view, which was a different 5-year forward view, there is an intention or an aspiration to have care navigators who are, again, based in GP practices on a neighbourhood basis. We undertook a programme of work called Releasing Time for Care last year with our general practitioners, and they wanted to look at a care navigation model. And we did a survey which showed that GPs were saying that up to 4 out of 10, some of them 6 out of 10 consultations were patients who were presenting with a non-medical need, often in relation to low-level mental health or presenting with depression, anxiety that was related to a wider determinant, whether that was housing, employment, education, and those types of things. Sorry, still see me. So what the care navigators will do will be based in those GP practices, and when a patient presents to a GP with that need that could be supported by this model or by the voluntary sector or by wider community assets, then the GP puts them in touch with that care navigator, who then signposts into that wider community asset. So I hope that helps a little bit.
Just finally, the only one thing I thought you missed out was the schools as a third sector. There's no mention of that, and that's a big thing now that, we should be joining up thinking here, because this is where they're coming from. And, the government has said every school has got to have a lead for mental health. And really, they're your biggest clientele.
Absolutely. So I mentioned that we had a mental health partnership board meeting earlier this week, and we had representations from schools and colleges at that event to help us develop our Trafford mental health strategy. And that was absolutely a point made at that session last week. So will become part of our plan and linked to this model too. So noted.
I'm sorry, perhaps what I should have clarified. I'm sorry, perhaps what I should have clarified. There is a therapy element to this team, and we will be providing high intensity and low intensity therapy.
Councillor Taylor, please.
Thank you. I think actually my question was around the care navigators, and I think you've answered that really. What would be interesting is in a few months' time, when you've actually implemented this scheme, is to have some evaluation and maybe some examples, maybe even some actual worked examples of, how that has enhanced, outcomes for patients, with some real stories about real people who have benefited from this programme, really to illuminate that somewhat. But thank you for that.
Yeah, more than happy to do so. Come back in.
Sorry, Councillor Lloyd, did you want to make an observation?
I just wanted to say that the Health and Wellbeing Board takes mental health really seriously across the age group. So it is starting with children, going on to adults, and then in later life. And just to say that we're looking to put schools with GPs as well in the neighbourhoods when we're doing the mapping of the local care alliance. So we will be looking at children, and I think as well schools play a very important part in recognising mental health with children. Yeah,
it's good to hear. Thank you, Councillor Lloyd. Councillor Brophy.
Okay, some of the points have already been answered, so I'll leave those ones and just focus on the ones that haven't been addressed. So I think it's a great report that in aspiration in terms of reaching it out and its sustainable policies that you're wanting long term. I think it's a great idea to have case studies as well. I think for me, it's kind of, does it work at the grassroots? Does it really reach the people it's meant to reach? And I'm wondering about particular groups. I know that psychological interventions can really help people with mental health issues, whether they're the low-level type issues or the high-level type issues, the people who need hospital admission right across the spectrum. I think the more severe mental health issues tend not to have the right kind of psychological support. The care is often very much around medication and there isn't much psychological intervention at all. I think that's a big gap, that the lower level of mental health tend to be more likely to access IAPS and the psychological services. To me, that is a big gap because there's a missed opportunity for intervention, and those physical problems that you want to long-term mitigate against, if you're not addressing the psychological issues, then it's a bit of a non-starter to address the physical issues, because the two obviously link really closely together. So I think the psychological support will have a big bonus in terms of the physical impact as well on things like smoking. You're not going to address the smoking behaviour unless you've also addressed the underlying psychology and behaviour issues there. The gap, I think, for me is there isn't anything about particular hard to reach groups. What about people with learning disabilities who are particularly vulnerable to mental health issues? I think, again, the points have been raised about schools. It's well known the young people who are suffering with the impact of a learning disability. Sometimes there is a gap in service from when those young people leave school and go on to adult life. And that particular group is extremely vulnerable to mental health problems. And I think more can be done to reach out to those groups that maybe haven't accessed services. So I completely support the aspirations, but want to make sure that it is really working at the grassroots, reaching out to the vulnerable people with learning disabilities. And I wonder how much the GPs can make a difference here, because somebody talked about it being an educational programme. Perhaps the GPs themselves need to be more aware of what the services are and who can access them, because many GPs aren't referring on to the psychological services that are there.
Any points on that or agreement?
Just we are currently going out to work with GPs and talking them through the offer, taking the point in terms of ensuring that we get those hard to reach groups. Often the referrals will come through the GPs, and the GPs will know who's in their community. So it will be linking with those GPs and making sure that they help us to identify the right people, and we're targeting that right cohort, really.
Very much. Councillor Duffield, please.
Thank you. If I'd realised it was going down this route, I would have done an interesting at the beginning. I work in North Manchester with the Be Well service, do part of that. So just so you're aware of that for my next question. And I've just wondered what learning you'd had from that. Obviously, that's a year in now, and that's obviously spreading across Manchester with different providers. But I just wondered what your learning was that you can bring across to Trafford from the North Manchester service. I think one of the things we've learned there is that engagement with GPs is challenging. They are laws unto themselves at times, so they're self-employed businesses, obviously, and just I know that some of that's been highly challenging in that engagement. I just wondered also sort of what numbers are you talking about in your first year and your outcomes there, and then your sort of integration with I know you sort of said housing providers and the other third sector, but some of that third sector needs funding to be stable to be that point on as well. And I just wondered where sort of some of that work was on that sort of more sustainable social prescribing model as well. Thank you.
Yeah, so in terms of learning from Be Well, we've been working with Pete Smith, who you'll know very well, in terms of he has influenced the model because we've wanted to use the experience in terms of what we already have in GWMH, and we have some fantastic teams that we're learning from. So the lead from this has been working with Pete, who's been excellent in terms of helping us to develop our model. So that's been really good, and sharing lots of the interesting work that you've already done in Be Well, and we're very excited about that service, as you know. In terms of engaging GPs, we know that's difficult, but we have the support of our colleagues, and we've already been working with, we have GPs in the implementation group. We've already started to talk about it across the LCA and to get these messages out. I think it's really important. You're right. People are sometimes difficult to engage, but what we think is that this will be a model that really does support those GP practices, and they know, and you know who these people are, I think, and we're reliant on those GPs getting the right people and being able to support us to get to those people and support them. I can't remember what the other question was. I'm sorry. We don't know numbers. We've concentrated on quality. We don't know how many of these people exist, but what we know is there is a need for this, because we are told by our GPs just how many people are recurrently coming to them with, like you say, multifactorial issues. They're not just health and social care. There are a number of issues, and one impacts on the other. So absolutely, we don't know, I think, how many people, but we're concentrating on making sure that we give a quality offer to the group of patients we can identify. We need to be very clear as well with who those patients are, I think, or who those service users are, because I think it's really important that we target the right group here.
Sorry, Chair, could I just add to that point as well, and to the previous lady's point? So just a little bit more around GP engagement. We've done a fairly intensive piece of work with our practices across the neighbourhoods over the last couple of months as part of a primary care strategy development. And this service it's probably the feedback that we had from most GPs was about the need for this kind of a service. So they're engaged, and they've been really involved in the design as well from the bottom up, as John said, part of the design group, part of the steering group. We've actually had a GP education event today, a Trafford-wide one, and this was presented again to the practice managers, really well received. So I think we've started the GP engagement right at the beginning of the design process, which I think will help when we come to implementation. You asked about third sector funding and sustainability. So sustainability of this whole service is one of the key outcomes. We need to demonstrate success and impact as a system, which isn't just around the third sector, it's across the whole. So that's a really key outcome in terms of sustainability. And we presented to the Trafford Voluntary Sector Forum yesterday, again, this model, and talked to them about how we can work with the third sector to collectively be sustainable, not always about CCG funding or local authority. So that was a really positive discussion. And then the other thing I wanted to say was just about the hard to reach groups. I think one of the key elements of this model, and it's linked to volunteering, is that it's not just about patients who come into GP practices, but actually we can go and find people, because we'll be linked to volunteers and community assets. So there might be people out there that we actually find through that volunteering mechanism and bring them into a service rather than wait for people to present. So that's a really key feature of the model, just to answer that question. Thank you.
Dan, you wanted to just make an observation before we...
It was really just to say that obviously this is a new service and we'll be learning, and we're doing that together as a collective group. And I think it's amazing, because it's going to help us to inform our commissioning strategies for the future, because the more that we understand that what people are presenting with and what their needs are, the better we'll be able to commission, particularly with the voluntary sector over the coming years. So it's, we're very, very supportive from a social care point of view.
Thank you. Councillor Mrs Brewer-Morris, please.
Thank you, Chair. Just a question. The model that you're implementing, has it already started in Manchester? Because in my surgery, we have a focused care team, which does, and it's excellent, because we know which patients are hard to reach. And they are doing amazing things. They're liaising with our hard to reach patients, getting them into surgery, getting the benefits sorted out, getting the housing. And I think it's just a pilot in Manchester, but I have to say we've had this focused care team now for a year, and it's amazing. It really is amazing. Thank you.
We do know that there are some high impact primary care teams, I think, in Manchester that are growing. We do know that they've grown without the support of mental health. So it's something we're looking to support in terms of a mental health offer within those high impact primary care teams. So yes, there are models, I think, across the country of high impact primary care. This is I think, a more integrated approach, because it involves the voluntary care sector and lots of our partners. I think Trafford's doing it a little bit differently, and I'm quite excited, I have to be honest.
Thank you. Heather.
Thank you, Chair. My questions are more practical. It's very hard from the paper to judge what the size of this team is, so and what the investment is, and how long the investment is being made for. And I'd also be interested to know, because I've heard various stories, have you actually recruited to all of these posts? So in terms of numbers, if you could split the numbers down by the care team and the neighbourhood team, that would be helpful. Thank you.
We will be able to provide that information. In terms of recruitment. Recruitment's ongoing. We think this is an attractive team, and we think we will be able to recruit. We will recruit from a GMMH perspective, and we're in discussions with the voluntary care sector organisations in terms of how we best utilise their expertise as well. So that's part of the design group, and we're having those discussions now.
I'm sorry, that's a bit of a vague answer. I mean, what's the level of investment, and how long is the investment for?
Do you want us? We can provide a breakdown of everything if that's what you need.
If you can't do it now, you can always
we can
provide what you share that, but we could do with that information.
I'm more than happy to.
So some of that information is to hand now. So the service is being funded through transformation funding, which, as most of you will know, by its nature is non-recurrent, to test the change, and that's really important. Why I mentioned sustainability before. So from the 1st of April, within the financial envelope, we're probably looking at approximately 12 months worth of funding. So the real push on for that implementation that we've talked about, to really prove the difference, prove the impact, and prove the benefit to the system. But we've entered into negotiations with GMMH, and they're fully aware of that non-recurrent nature, and are working with us on that. In terms of the staffing structure and the breakdown, as I mentioned to the other lady, we will provide the operational detail that we can circulate that around. That's fine.
I'll have Councillor Slater, then Councillor Mrs Evans, then we'll move on, if that's all right. Councillor Slater.
I was going to ask whether the voluntary sector actually geared up to support us around that, but I think some of the information that you have already given us does cover that. I think it looks really exciting. I think that, you know, we do need to be doing more of those people who present at hospital quite often, and when really they should be getting some more support in the community. I think it'd be really helpful if you can provide that detail that you were talking about off page 9 in our paper. So what you'd already answered for me, so thank you very much.
Councillor Mrs Evans.
Yes, mine is once again a little figure orientated. So I think I grasped it right when you said that you didn't actually have the figures to hand about what the GPs had said, the numbers for need. So we're building a program around something that we don't necessarily have data on, which sounds a little bit extraordinary. I'm not saying there isn't a need, I'm sure there is, but I think we should know how many GP referrals, how many people have come to that, how many people they found they need it to really understand it. And then on top of that, if it's the hard to reach youngsters, and we do know about that, there is a significant, problem perhaps in that area, then I think that's something that we should, the new kind of model is something along the Facebook line, isn't it? If you want to get to hard to reach areas, the whole social media aspect here that must be very prevalent. And I'm not saying that you're not doing that, but it isn't just about them. They won't present at a GP surgery. That's not what they do. They present online. They present, the parents often say, I didn't know this was happening. And yet online it's happening. There must be a different way of reaching out. So one is the figures, there isn't much clarity. And the other one is that it must be an innovative program if it's going to work in pups are more difficult to reach younger area. And in fact, I'm not sure that it's just, the following on those sort of Facebook sites is massive, and you can get a different cohort completely who will never turn up and present in a GP surgery. Just a thought.
Okay, so in terms of numbers, I think the question was asked about what are our anticipated numbers through the service in year one, and at this stage we can't really say that. That doesn't mean to say that there isn't some evidence and data on which we've done the modelling of the service. So when we initially developed the model as part of the Transformation Fund, we absolutely had to do some modelling of need, of evidence. Obviously some of this is unmet need and some people that we won't know about, so it's never going to be absolutely scientific, but we do have some data and evidence on which the modelling has been done. So again, I don't know the numbers off the top of my head, but we do have that, so I can give you that assurance. And in terms of digital and other solutions, absolutely, that's really key now, not just to this, but to all of the services that we commission going forward. And again, if you've read the 10-year plan, which some of you may have done, there's a real emphasis on digital enablers to access and to quality and to improvements. That's something that's running through all of our commissioning plans at the moment.
Thank you very much. If there's no further points, we're asked to approve, note and endorse the report. Are we content to do so? Super. I think we obviously are. It is clearly ambitious. There's no doubt of that. And I think that, it demonstrates, and as if we didn't already know, that the existing situation does not provide parity of esteem. And maybe it's the cynic in me, but I think you've got quite a long way before we're even approaching that, which obviously is not, it's a problem that we have. It's not necessarily a failure on your guys' part. So we're happy to do that, and we do hope that more will come along, and we hope you'll keep us informed on this as well, because obviously it's a very, very important, hence the length of the debate this evening. It's a very, very important aspect of our residents' healthcare that we'd like to see addressed. So thank you very much for coming this evening, guys. It's good to see you. Moving on, if we may, to agenda item 7, which is Trafford Palliative Care and End of Life Update from the Trafford CCG Senior Commissioning Manager. Do start when you're ready. Can we have one meeting, please, guys?
Good evening, everybody. My name's Alex Cosson. I'm one of the Senior Commissioning Managers within the Integrated Commissioning Directorate. I've been asked to present a summary update, really, of what the work we've been doing around palliative care and end of life and the improvements in Trafford. I know you've had the paper, so I won't go through all the detail, but I'll pull out some of the highlights and obviously take any questions afterwards. The first thing is around, I suppose, our current performance, and we're actually monitored against an array of end-of-life indicators, but I've pulled these two out because they're the most prominent ones, and actually indicators do just indicate, and it's around the story that we develop. So the breakdown of place of death in Trafford, within the graph, it looks rather static. However, we have made improvements through the reduction of death in hospital since 2015, and most significantly is around the new indicator for the improvement assessment framework, which is around the percentage of deaths with 3 or more admissions, emergency admissions within the last 3 months of life. And we're actually performing the best in Greater Manchester on this figure. This is a new indicator that was introduced in November 2018, and it was very much focused around improving quality. So what does it signify about the anticipatory planning, and when people need unplanned care or urgent care, when is it delivered, and how quickly is it delivered, and how accurately is it delivered? But as I say, the indicators themselves only tell part of the story. So the key work that we've done over the last 12 months is actually understanding what's happening as a system and how it feels for both staff, families, and patients. We undertook a multi-stakeholder workshop in December 17 and January 2018. It was very well received. We had our primary care community colleagues there, nursing homes there, the Christies, MFT, Salford Royal. So it was very much a stakeholder collective view, where we did a self-assessment against the ambitions framework. And that was looking about how we feel as a health and social care economy are performing against the ambitions for palliative care. I've listed them both within that page, but what that self-assessment did was actually identify the barriers that we have in Trafford, areas that we can improve, and actually some of the key priorities that we need to work for if we're really going to improve both the system and the way it works, but how care feels to patients and their families. I think it would be fair to say that they're not surprising. Some of them were known already. I think they're shared difficulties across Greater Manchester, which is part why we did this workshop in partnership with the Eastern Cheshire and Greater Manchester Strategic Clinical Network. It was understanding what could we change as a system in Trafford on our own, and actually what did we need to do collectively as a Greater Manchester response. So some of this work has actually gone on to lead and develop the Greater Manchester standards for palliative care that are coming out, where we've needed a collective response. Over the last 12 months, we focused on what we can do within Trafford, and that's been looking very much at education, shared care records, how we can make advanced care planning happen on a more regular basis in a more meaningful way, and also looking around how we can make care more personalised, more person-centred. So yes, we need to make sure the system works and care is coordinated, but it's also really important about how that feels, because I think sometimes it can be a disconnect. Bearing that in mind, some of the key pieces of work we've done is around education and training, both for our GPs. So we know one of our challenges is actually identifying when people become palliative earlier, because the earlier the people we can recognise this, the more advanced care planning that we can do and the more systems we can get in place for that patient. So we've had input from palliative care consultants supporting our GPs around early identification and increasing their confidence around end-of-life prescribing, particularly because there are some interesting guidelines that have come out over the course of 12 months. We're also going to do some additional training in the upcoming quarter around person-centred conversations in primary care, and also helping patients to understand how they're managing their long-term conditions. With regards to shared care records, it's about utilising our EMIS and our systems and sharing those records. So we do have EMIS in our practices now. We also have them in our community services. With the one template for palliative care, that means that all the important information, such as lasting power of attorney, do not resuscitate, consent, whether a carer is even aware of the cared for's condition and where they are in their journey, that's all documented and can be seen across services, which is really key. GPs will also be able to see and are able to see whether that's been updated by one of the community teams, which is important. So it doesn't just happen, stay static and goes on the shelf. People are aware that they are being updated. What we've also done to promote that is put prompts in our long-term condition registers, because it's important, again, to ask that question. We get build it in GPs' minds to say, would you expect this person to die in the last 12 months? And if so, think about putting on the palliative care register. One of the most exciting things that I'm excited about in the last couple of months is the opportunity and funding we received from the partnership, the Greater Manchester Health and Care Partnership, around person-centred approaches. And this is only a small amount of money, but we're working with St Anne's Hospice, and that's really looking around that person-centred care. We're focusing on our nursing homes, and it's split, and home care providers, split into 3 projects. The first one is taking 2 care homes that we know actually from the nursing element, the advanced care planning, we're quite confident that they are doing well, they're on solid ground. So how do we make that more person focused? So what we're looking to do there is a 1-person profile. So as an individual, this is what people appreciate about me, this is what I want, this is what I like, this is meaningful to me, and this is what I don't like. And it's about putting that in a plan for the end of life. So these are my wishes at the last few months, last few weeks, last few days, and making that meaningful. The second part of the projects is around making sure the foundations and processes are in place within the care homes, and making sure that they're embedded within the ethos of those homes. And the last one is home care. We know we've got a lot of work to do with the home care providers, but we also know that actually they can be times where the home care staff or the families go into crisis, and that leads to a hospital admission. I won't go on because I know there's the dementia strategy on the agenda this evening, but one thing that I think is very important is that palliative care and end of life isn't seen in isolation. Actually, it's embedded as part of our considerations with all our long-term disease priorities. We knew within dementia that actually the very nature that you need to have these discussions much earlier than you do in other with other conditions, we made it a priority. So within the Dying Well part of the dementia strategy, we've done some key actions that we'll be looking at moving forward. And some of that is starting with the foundations. Do we know that advanced care planning is happening for these patients? So very much some of the work in the first 6 months of this year is establishing the baseline. And I suppose the other bits speak for themselves, but one of the things I think is absolutely key and came out is how we engage with the public. We need to break down the stigma, I suppose, as we did with mental health, about talking about death so that families feel more confident in talking about death, and that people know how to access bereavement support. So in May 2018, we undertook a roadshow of Dying Matters. We went to each part of the locality across Trafford, did a series of different activities, many of them fun, just to kind of break down that as a public health campaign. We also did Death Cafe in Altrincham, with one of the very prominent stories for me being a 21-year-old who had no one to talk to about the death of her father, and actually she found it was a very accessible and meaningful experience for her. Our priorities moving forward are really building on that, the knowledge that we found out. We need to reduce the variation that's happening in primary care about our being able to identify patients. So building on that, we have neighbourhood profiles and practice profiles so that GP practices can see what their palliative registers are like compared to their neighbourhood peers. And we'll be learning from our GM programme, as well as maximising the education and training programmes that are coming out of the partnership and the strategic clinical network around Train the Trainer, which we hope will help address some of the educational needs within care homes and the high turnover of staff.
Before we start, there's a point in page 5 in which you mentioned the funding you've secured from the Health and Care Partnership. It does say it's non-recurrent. Now, given that that is being partly at least used to introduce a specific role, has any thought been given to how that could become recurrent? Thank you.
So yes, the amount of non-recurrent money we received from the partnership was £12,000, and that was predominantly for a role to be able to go into each of the care homes and then build it into their ethos. So predominantly this is around making sure that those processes, having champions within the care homes moving forward. We also have a training cooperative for care homes as well. So part of this is taking learning around how we might be able to build some of this into existing things moving forward.
So it's not a concern that it's non-recurrent in this instance. Thank you. Councillor Mrs Brewer-Morris, please.
Thank you for that. I welcome this. I mean, end of life is the most important to all of us, for our families, for our elderlies, for me. I think about it. We all think about it. I just have two questions, and it's about the EMIS. You have the template now for palliative care on our GPs that they can access this. How is utilising EMIS? How is it improving communications between primary and community care? Oh, and the other one was just about training and the high turnover of the staff in care homes in the public sector.
Thank you. With EMIS at the moment, what it does, it provides all the data sets nationally that are for the electric palliative care record systems, EPACs, if I've got that right. And what that does, it captures all of the information. So it's there as a GP, as a gatekeeper for that patient's care. It goes as far as documenting, signing off the death certificate and having another doctor to support that, which can be traumatic, I know, for families. That system speaks to EMIS in the community. So when the district nurses are out, when our supportive palliative care team are out as well, it means that they can have those conversations. And actually, the GP isn't always the best person to have those conversations with patients. It's the people that see them most regularly, whether it's a district nurse. So it allows them to update the system, and a GP to then go back in from primary care and say, that patient's decision's changed, or their medication needs changing, or there's been something flagged. So it just helps, rather than waiting for a letter necessary to arrive through the usual post, there's more immediate response that they can see.
And the district nurses now have EMIS?
Yes.
Oh, that's...
Councillor Mrs Haddad, please.
Sorry. Just to answer the care homes turnover activity. So obviously we are working really closely with the care homes on quality improvement, and turnover activity is a key part of that. So we're linking with the care training cooperative, with the CCG, and over the next few months we'll be starting to really feed the providers into that training. And the idea is that the worker is registered, so a lot of workers do move around, but they move around in Trafford. So we'll be able to track the training they've received, and that will transfer with them to the new home, which will save a lot of retraining activity and wasted energy.
So that portfolio
absolutely. So that's how we're trying to focus on it.
That answered your points. Yeah, super.
Again, thank you for the wonderful explanation of how you want to improve, and you've developed, build on the care that's already been developed by St Anne's and other services. My question really was a practical one, trying to understand and really having a concern about how you've said in this description that the success of, you want to take the success of St Anne's to the care homes, and I can see that you want to be, you want to be a part of the team that cares for the person at the end of life, and give them what they want. But can they actually get that in a care home where, they don't have the same? I'm presuming they won't have the same equipment as a setup like St Anne's, and bridging the gap.
Hi, I'm Karen O'Connor. I'm one of the community Macmillan nurses. So we do work, we go into the nursing homes. There are issues, that's correct. And, they do need a lot of education and training. But they have, some of the homes are already up and running with end of life care anyway. So the ones that aren't, they're the ones that we need to work more with, like this project's going ahead with. So that, they do have syringe drivers. As obviously staff have got to be competent. So the ones that aren't don't use syringe drivers. They then have to give PRN doses of medication from a safety point of view.
I mean, as we know, this equipment's very expensive. So, for a care home, where do they get the equipment from? How do you manage to facilitate that?
They usually will buy the syringe driver. It's about £1,000 for a syringe driver. And the likelihood is they probably may only need one anyway.
That's one piece of equipment,
Yeah.
but as we know in this type of care, sometimes you need a range of equipment that's very expensive.
Yeah.
So for a care home to provide that,
I mean, they already
it's
have a
ambitious.
lot of equipment, for example, the beds, etc., and everything. So I think one of the main things, usually from our point of view, is as long as they've got a syringe driver and they've got the staff that are competent to use one.
I guess that even though fantastic though St Anne's is, there will be some patients who are more comfortable being where they are. So that's fair enough. Heather, please.
Thanks, Chair. Just a couple of points. I'm not clear whether we know how many people actually die in care homes. I don't know whether any figures are collected, is one issue. And the other thing is we are under contract as Health Watch to the council to visit care homes, and all of the reports come here, but I'm not clear how widely they are shared, particularly within the new integrated service, because there are lots of comments in those about care for people at end of life. And one of the questions that we ask of every care home is whether they have instituted advanced directives. The answers that we generally get are that a lot of them have, but perhaps not everyone. But I just think that it's about being able to communicate and make the best use of the information that we do have available. But I am concerned about how many people die in care homes and how many are referred into hospital to die.
We do have that information. I don't have it with me today, but we absolutely do. There's also been a Greater Manchester dashboard, which means that we can see that across ourselves compared to Greater Manchester. So I can absolutely provide that. I completely agree with this variation across some of the care homes, and I think there's a lot of quality work going on around that. It's also part of the work, I suppose, around the processes that St Anne's is going to share with the care home project, is around actually, is this in place? Is it accessible in a way? If you are a home that has temporary staff, for example, it's actually embedding some of those practices and really understanding, doing an audit of some of the barriers that might exist and supporting those changes to take place. And actually the way we evaluate that is what we're going to look into in 1920 about what other improvements we can make to make sure that's embedded across the system.
Councillor Duffield.
Thank you. Thanks for your report. I've just got a couple of things that I'm interested in. Just around the take-up of personal health budgets, is there more work that needs to be done around that? What's your view about where that's at and how the council supports all of that process as well? And if there's a practical example about how that's used, that'd be really interesting. And the other thing, just at the moment we're consulting on an older person's housing strategy, and part of that will be around our need for more extra care housing or not, and where do you see extra care housing in that sort of keeping people away from residential and within their own home, and having that sort of an end of life in their own apartment, probably, rather than moving on into residential or into other sorts of care homes? And what's your view on whether or not we need more of that and there's a better experience within that, or any other views that you've got? Thank you.
With regards to personal health budgets, they are quite challenging as an area. I think we've still got a lot to learn, and we are working with our Greater Manchester colleagues to see around best practice. With regards to palliative care, we're linking with St Anne's Hospice and those that are currently under their day care at the moment and having many of those advanced care plannings at the moment. They were part of those documentations, and what will happen is someone then becomes fast-tracked or CHC eligible. It will all be in place and be able to help support the care that they've decided. I think moving forward, we need to learn the lessons from the processes that are in place and see how we can actually make that a wider offer. But I'd say it's in its infancy as a programme at the moment.
If I can just respond to the point, we've actually been invited to be a representative on the Older People's Housing Strategy Task and Finish group. So rather than probably give a personal opinion now about extra care, I think what we'd hope to do is be able to inform and influence that discussion through that group. So it would be good to have that representation. Thank you.
Any more points, please? Dan.
Just to make the point that
residential nursing homes, extra care at home. It's your home, and you have a right to die in that home if you choose. But some people will always choose not to, because it's a very scary moment. And so the work we're doing is going to support us, I suppose, to really shift the numbers to people being able to make those choices, but in the right way, with the right support and the right pain relief, etc. And so we will make mistakes and we will learn, but it's a team effort, as you can see, and I think we've got some fantastic staff working on this.
Okay, it certainly sounds like a long overdue addressing of something that is a very serious part of people's lives. So thank you very much. Can we all note the contents of the report we've had, please? Thank you. Thank you very much for being with us this evening, guys. Thank you. Moving on, agenda item 8, the Altrincham Health and Wellbeing Centre update, which is in front of us.
Thank you, Chair. I'm Martin Pritchard. I'm the new accountable officer for the Trafford Clinical Commissioning Group. In front of you is a short report, which hopefully is fairly self-explanatory. I'll just add some additional comments. Clearly, we have a building which we're only using a small part of the building at the moment, and therefore my task is to work through with partners about how we use the rest of the building for the good of the people of Trafford. So what I'm doing is working through in 3 stages. The first is looking at health and social care use and the ways in which we can use the building for health and social care use, fitting into the ways in which we're working jointly with the local authority. Secondly, looking at broader public sector use, so beyond health and social care, other public sector agencies. And then thirdly, it's could be that we don't use all of the building through those 2 processes. So we're also looking at what other things that we could do to use that building. The preference is to use the space for health and social care. So that's the work we're doing first. But we're not waiting till we go through each of those processes before we do the other processes. So I've taken personal lead on this. We have a project board is set out there, and I have weekly meetings where we go through to have updates on where we are with these things. At the moment, I can't give you an update on the agreement of any signature of any use of the building, but I will do as that goes on. And what we need to do is both move quickly to use the building, but also make sure that we make sensible decisions in that, because this building is here for the next 30 years. So it's that combination of moving fast, but making sure we use the building in sensible ways going forward. So that's an update in addition to the paper, and of course happy to take the questions of this meeting.
Thank you. The report we've got in front of us doesn't, if I'm honest, Martin, tell us anything we don't already know or couldn't have worked out just by looking around us. There are, frankly, if what you say is happening, you can be a lot more concise than has been the case in this report. There's considerable amount of repetition and hesitation, in my opinion, in this report. It's unnecessary. It also needs stressing that as it clearly is, there are commercial sensitivities behind revealing the full details of what actual situation is. That needs stating, because the public are going to look at this and think that so nothing has happened since last time, which clearly from what you've said is not the case. So if you could please bear that in mind, and for next time, by all means, be a lot more concise than here, but it needs to be very clearly stated, because it isn't in here. Councillor Duffield, please.
Hi, Martin. Welcome to Trafford. We appreciate that you're new in this post, and there's a lot to learn and take up. I think if we look at the Altrincham Health Hub as an issue in itself, I think there's tremendous concern in the people of Trafford about how we got to this point. I know that there's a report being commissioned about how we got to that point. Our expectation is that that report comes to this meeting at some stage. Whether or not it's going to end up being a private report, I hope that's not going to be the case. I think the people of Trafford deserve to know, especially the people of South Manchester, deserve to know how this has happened and what we've got to this place. This is public money. This is scarce public money. If this building isn't going to be used for the reason that it was developed, I think the story behind that is important learning, but also important for us to be very open and transparent with what has happened here. We get that this isn't a council issue, as in that when it happened, it's a CCG, but we're integrated. We're all in this together now to some extent. But we also need to know that that there's going to be any council money or any capital money or any revenue that's going to be needed about why, what do we need to learn. But I think we're probably disappointed that we're at this stage and we still don't really know what happened. I think I get contacted by many members of the public who are desperate really to know that they've promised this thing and it's not happened. And I think us understanding that as a health scrutiny committee and as a council, as an integrated service, and for our residents, it's going to be really key going forward. And I would hope that John Rouse isn't that report will be made public. Thank you.
Okay. Taylor.
Hello, hi, I'm Sophie Taylor, one of the councillors for Clifford Ward. So it doesn't directly affect my my constituents. However, and I think Councillor Duffield has eloquently expressed the concerns we have. And I just do want to emphasise that we must have a lessons learned really, because I mean, it is nothing short of scandalous really that we find ourselves, and I know you're new to this role and you're not personally responsible for that, but I think, you know, any part of going forward has to be some lessons learned really, how vast amounts of scarce public money was sort of sunk into an almost like white elephant project now, and we're sort of scraping around to try and find useful useful work for this building now, you know, that is stuck on very expensive real estate, isn't it? And you know, we're struggling to find occupants for it really. So I hope that is something that we can have brought to this committee in a public in the public domain really, and you know, some proper interrogation of what has happened does take place really. Thank you.
To respond to that, first of all, thank you for the feedback on the report. I mean that genuinely. So on future reports, I will take those comments on board and try to produce something which is more helpful. Secondly, I just want to make clear that the report that's been commissioned is not a report that's been commissioned by Trafford CCG. It's a report that's been commissioned by NHS England. So it's not within my gift to make promises or agreements about bringing it back here. I will, though, in my conversations with NHS England, make clear the things that you said to me about wanting to see the report and understand those things. None of us want to be here today having this conversation, and I know that. And thank you. It's, you know, it's not from decisions that I've personally made in the past, but I absolutely understand that we are committing and using public money that we could be using on other things. So all I can do is get on with, you know, working out what we can do with it in the future. So I take on board all the things you said, and I will go back to NHS England and make the representations that you said about sharing that report.
Just very briefly.
Martin, I think it's one of the reasons for saying that, Stephen. I think it's important for us as councillors to have that on public record, that our expectation is that we will see that report, and that and our residents know that that's what we're asking you. We understand that the limitations that you have in this regard, and obviously the council has, but I think it's important for us to make it our robust representation to NHS England about our expectations, however they are received. Hopefully they'll be received positively.
I'm sure that's been minuted, Councillor, and obviously it's a benefit of us being webcast, isn't it, that people will see what we're saying. Councillor Mrs. Brewer-Morris.
Chair, I have to agree with my fellow councillors here. I really find you've given a list of the services that you would like to have in this building. I mean, it's fantastic. Nursing practice, nursing children, long-term GP, everything. And then the paragraph underneath, discussions are progressing well with several potential tenants. So we go from this wonderful, illustrious list of services to a pharmacy and a cafe. That's really disappointing. And the other thing that worries me, it is said in the report, it is important to note that there are no impact upon current level of service delivery, and therefore So you're saying that actually these services you want to offer are already being offered to Trafford residents, if I'm correct. So this building is surplus to our needs, requirements? Thank you.
Thank you for the question. Sorry again that the report doesn't make clear what the intention was. So it was actually meant to be reassuring to say that the level of service that we've currently got won't be reduced by moving into the building. So it's meant to be a positive statement, which clearly doesn't come across. And I'll again take that feedback.
It feels like, very quickly, it feels like we've got the services. So, you know, if we do put flats in later, well, we're still covered. Thank you.
Mrs. Haddad, please.
Actually, I was focused on some of the content that my colleagues have already just covered, especially Mrs. Brew-Morris, but the line that says that our approach is to secure a primary care presence within the development as soon as possible. I'd like to really focus on that because, you know, that's what it was meant to be, isn't it? So I take from that you are trying to get services in there, and I, you know, wish you well and hope you'll come back with some positive news.
Absolutely, because part of that is once those services are in, it becomes more attractive to other services such as pharmacy or dental or other things. So that's why I was trying to get across in the report the staging of the approach, which is first of all to start with health and social care usage, then look at broader public sector usage, and then if we have to look at other usages there. So that was what I was trying to get across in the report.
And I mean, I have to declare an interest in that. I live locally, so I want to see this up and running. And you know, but the other point I briefly want to make is that Trafford Hub that operates from the GP practice on St John Street. Do you know about that? Because that's a kind of quite a small building, quite small facilities, and yet, you know, there's been quite a, you know, this 7-day service being developed there, and I just wonder whether that's somewhere that you could tap into and get some movement.
So this is day 16 of the role. so I don't know all the detail of it, but Sarah's looking at me like she does know more of the detail.
So just in terms of that sort of our programme and extended hubs and access across Trafford itself. So absolutely, that's what we want to keep developing as such. I think the issue is about access as well. So where we actually put things and making them accessible. So one of my sort of things I say all the time is really primary care needs to be within a pram push of the people that use it. And so one of our things then about moving is about remaining an accessible service. So I take on board completely what councillors have said about that whole range of services and what it means. And when we're doing the modelling, we need to make sure that if we do move services to the hub, they are accessible to the practices and the residents and the patients that are currently using them. So that is part of that modelling. But the extended hub is part of our whole programme of work for accessibility across all of Trafford, for all of Trafford residents.
I just want to say, from a
And so I think that depends on what services we put in. So in terms of if we put practices in, then actually about how accessible it is to practices and the residents of those practices that, you know, tend to be around a particular locality. And I think that's what Martin was saying about looking at that health and social services and the different services we might put in. So some of them absolutely we could put in that maybe is accessible to a much wider range around Altrincham, because in terms of how you get to Altrincham, the transport routes, and we need to look at that really. I think originally it was very much about
a practice element and what we need to look at as a much more integrated health and social care element if we're going to put that in that range of services. But they do have to be accessible, and we do have to do that accessibility modelling of anything that we do put in to make sure that we're not actually taking access away from people by moving services that they currently have.
Just one more point, Councillor.
I just want to push one more point, and that is that, you know, that Trafford hub, people come to that GP practice from all over Trafford, so I think there is some leverage there.
Thank you. And just to endorse what colleagues have said, it is a rather gaping, obvious failing in the service that we are providing Trafford residents, that there is this huge, great, as Councillor Taylor pointed out, white elephant sitting in the middle of Altrincham. I happened to be in Altrincham this afternoon, potted into the library to have a look at the new facilities, and was wandering around and thought, oh, what can I see out of this window? Oh yeah, nothing, because it was the reception area of the new GP that isn't happening. It is very, very obvious to our residents. It's very deeply concerning to our residents. The press reports, obviously, you know, have been made it very obvious what is happening. Not necessarily, I think, from your guys' perspective, necessarily entirely accurately on occasion. I think in order to make sure that we get some kind of progress on this, you do need to move fast. And I appreciate you probably feel like you're clearing up a mess that was made by previous people, but I do implore you to please, and if necessary, let us know offline what's happening. If it's not in time for the next meeting, if something happens before and it can be shared, please let Alex know, and he will, or myself, and we will disseminate that to the committee, because it's really important that we know what's going on. But thank you very much for all your work. I don't envy you your job, but you know, you're clearly taking it on, and thank you very much for being here this evening. So thank you. Moving on then, if we can, to item 9, the single hospital service update. And Stephen's been sitting there very patiently throughout the meeting, so thank you as always for joining us, Stephen, and please do go ahead.
No problem. I've got a kind of regular update. I've not got anything big and new to announce, so I maybe won't try and use up too much of your time. I just will go back briefly to the start for people who haven't heard all this before. I guess most of the single hospital service drive came initially from Manchester, and the Manchester Commissioners and Manchester City Council in the end decided that having 3 different hospitals in the borough run by 3 different organisations was not a clever way to run hospital services. They set us out in the direction of trying to bring those hospitals together into one entity. Last year we managed to get University Hospital South Manchester, which ran Wythenshawe and Withington, and Central Manchester Hospitals Trust, which ran MRI and the Oxford Road services, along with Trafford General and Altrincham, together into one organisation. And we are still trying to make progress in bringing North Manchester General Hospital out of its current management arrangement as part of Pennine Hospitals into the Manchester Trust. There is that Manchester focus to it, but we try never to lose sight of the fact that creates an organisation that provides the vast majority of the hospital care for Trafford residents, so that we try and keep that at the forefront of our minds at all times. In the report, I've got a bit of an update on how things are progressing. So really just around those 2 phases to the project, having completed the merger. Obviously, there's no point in just doing a merger if you don't actually try and do things to improve the quality of your services. The driving thoughts underneath all this are that creating single services with groups of clinicians working together across a bigger footprint allows you to address some of the real difficulties we have with staffing, allows you to create some economies of scale, and allows you, importantly, to iron out variations in care around the system so that everybody can get equal access to the same good quality care. I think as we're bashing on with it within the existing organisation that brings together the old South Manchester and Central Manchester functions, we're making fairly good progress on that. What we said we would do is produce a year 1 report. So you've all got the year 1 report. This report is aimed at being accessible or of use to quite a variety of audiences. So in some places it's got some reasonably technical detail that might be of interest to people who are interested in mergers and how you do them. It's got quite a lot about the nuts and bolts of what we've actually done, how we've created and structured the organisation. But it then tries to go on to demonstrate some of the benefits that have been delivered. I would say the year one benefits are probably not on as grand a scale as we would hope the benefits in subsequent years will be, because it takes a while to come to a conclusion about the best way to organise things, but we have still delivered benefits in the first year. I've talked through some of those before here, so I won't go through them in detail. Some of them are also highlighted in the report, the covering paper, but I'm happy to take questions or to go into more detail on that if people want. The other thing the report tries to do, it tries to communicate some of the messages in a variety of ways. So we've got some quotes as well as some case studies and things of that sort in there. At the back, we've got a lessons learned section. I think the feeling overall is that the merger has generally progressed fairly well and has delivered most of what we would have wanted it to. So there's no big headache or hiccup or anything of that sort, but there's always something to learn. So we've got, I don't know, 4 or 5 areas that we've picked up in the back where we think just these are things you need a bit more focus on if you're doing the same exercise again, or you need to think about earlier, or that sort of stuff. So it's an attempt to be reasonably candid, and I hope that comes through. I hope people find the report accessible, and we're using it in quite a variety of settings. The only other thing I'll say then is about the North Manchester process. So timescale for North Manchester, we've been talking about for a long time as a window that was in between October 2019 and March 2020 as the timescale in which the transaction would happen. 3 of the Pennine hospitals would go into the Salford Trust under the Northern Care Alliance label, and North Manchester General would come into MFT. I would say of that window, we are definitely at the back end of it. So our planning timescales are all around 31st March 2020. And even there are risks with that timescale, even, we're working hard to make sure we can deliver that. One of the things you do when you go through these exercises is you look very hard at the organisation you're acquiring and try and work out how many problems and difficulties there are with it. North Manchester has not enjoyed much by way of investment and probably hasn't even had very clear strategic leadership. I'm not wanting to be too critical, but it's not. I don't think it's not benefited from being part of the Pennine acute setup. So there are problems with North Manchester, and we can't take on North Manchester and destabilise the rest of MFT. So we need to know that we have got a plan for how to deal with those challenges, and that's a lot of what we have to think through over the coming months. That's probably all I'll say, if that's all right. Councillor Chilton, happy to take questions.
Thank you, Stephen. I think and it's been much rehearsed at this committee, both my and various other members' concerns regarding the integration of North Manchester. I'm sure it's a challenge to yourselves. While I can understand the rationale behind it, I would just ask that you keep us updated as to how that's going and any potential knock-on effects on the rest of the trust. I would say again, whilst I welcome, there was particularly, and hopefully maybe even having taken into account the feedback that was given at these meetings, that there is a sort of a candid section, if you like, at the back of the report, detailing things that you've improved or have learnt from the process and things that could have been done better. I think what potentially would still like to see, the trust gives these same 3 examples again and again, 4 examples of services that have been improved or seen improvement as a result, potentially, theoretically, of the merger. I think we would like to see even if it's not necessarily in a report that's circulated sort of enormously to everybody, but just to this committee, a breakdown of all the services, how they're doing, and whether or not they have been impacted. And obviously, even if that is a difficult judgment to make, I think it would be useful to see where all the services are sitting, not just urology, urgent gynecology, and various things like that. Whether they have improved, whether they have stayed broadly the same, or whether there's been a few problems. So perhaps if you guys could go back and maybe bring that back to a future committee, I think we'd really appreciate that. So just if that's okay. Councillor, oh, sorry, Sarah, you just want to...
Just in terms of impact, because I know Stephen was sort of saying about sort of, predominantly Manchester, but I think it has had quite a big impact on us as a system. And one of the things I think has been visibility and relationships, particularly with the chief exec of Wythenshawe, Trafford, Withington and Altrincham, so Mandy Bailey, who's now she is our link to the whole of Manchester Foundation Trust. So for us in Trafford, it means we have access to the eye hospital, access to MRI, access to RMCH through her as chief, which is a real difference to what we had before in terms of looking at redesign and looking what that actually means in terms of that. MFT's also played a lead role in the Local Care Alliance. So in terms of actually how we do for the winter, bringing all the winter plans together, that's been a big change for us. Looking at services we're actually taking into the hospital, as well as how we might redesign now and bringing services out. So again, the chief exec of Wythenshawe's acting as our lead for that across the whole of MFT. And obviously, just to make a point from last time's scrutiny, MFT now are the preferred provider that we're working with in terms of our community services. And we're in due diligence with them now in terms of how we do that and link to the future. So I think for us, this sort of single hospital system actually has been made it more visible in terms of Trafford because of the leadership roles that people are playing now in Trafford and engaging far more with us as a system than we have before. So we're more assured by that, to be quite honest.
So all of that is helpful feedback. Just to come back to your point about getting a sense of the generality of services. I mean, I accept entirely that. I've talked you through some of these examples before. They are the things that were deliverable in the first year. The thing that we've got coming up, and it's referenced in the report, is a clinical service strategy for the organisation in its entirety. Now, that's taken quite a bit of developing. And it's not going to be in a public version, I think, until kind of May time, April, May time. But I wouldn't see any difficulty in us coming and explaining what the clinical service strategy is to you. And that will do more of the big scale thinking about, how many locations do we provide cardiac services in? How many locations do we provide head and neck services in? That sort of thing. So that's not far away from being ready to share. And I think that would answer quite a lot of your questions.
Sorry, Rob, and just to sort of say we've been involved in that. So it's not something MFT's done by itself. We have been involved with other CCGs and clinical groups in looking at the 20-year strategy.
Super. Thank you, Sarah. Councillor Mrs. Brewer-Morris, please.
Thank you, Chair. Thank you for the report. It's really good. And I've enjoyed reading it and have read it. I was afraid Wythenshawe would be downgraded when this was first floated, the single hospital service. But I'm happy to say I think it's really working for residents. When I talk to people in Timperley and Altrincham, I think people are very pleased with it, and which is good. One question I do have, and it's about the 20,000 staff that you have. How do you retain them? And that's a heck of a lot of nurses, I have to say. And do you have a lot of vacancies, or are you retaining your staff? And the other question was, and you may not be able to answer this, you know that student nurses no longer have a bursary. Have you seen the effect on trying to recruit nurses, that nurses don't want to go into training because they might be older nurses and just can't afford to access that training? And the other one, what Chair just touched on, all the good things are in the report. That's wonderful, the emergency gynae. But I've asked a couple of times now, how long is the elective waiting list? Is the gynae waiting list for elective surgery? Because I've heard that it's quite a long time. Thank you.
There's a few things in there. Just let me do a couple I can tell you I can't answer. So I wouldn't know off the top of my head the effects of the changes in the bursaries. I don't work in the area of nurse management. So more broadly on having such a large staff group, MFT has challenges on staffing like every other NHS organisation does. Generally, I don't think it's the challenges are as difficult in some other places, and that is partly driven by reputation and people wanting to work there. And to be honest, I don't think anybody wants to work at MFT, but the brands of things like Royal Manchester Children's and St Mary's are easier to recruit to. We're doing some joint recruitment already with North Manchester because their recruitment problems are enormously difficult and on a different level of difficulty to what any other organisation has got. And to some extent, we're seeing that we can attract in people if they know they're part of the MFT family. So there's that advantage. The other thing with a big staff group is just that you can offer people career paths and routes. And so there's all sorts of things that the scale gives you. I'll just give you one example. Actually recruiting able young NHS managers is not terribly straightforward. They can be quite hard to get. The NHS runs a big national management training scheme. MFT is now big enough to run its own internal management training scheme. So we take our own graduates into a management training scheme and we can circulate them through the organisation and produce people, frankly, of a really good calibre who come off a conveyor belt and we just recruit them. So that scale does give you some advantages. The gynae waiting list. So performance at MFT at the moment is challenged as it is challenged in lots of places. So, on A&E, we are second top in the city, but nobody's doing great in the city. Nobody's hitting the target. So we're trying to use the capacity and the opportunities to flex capacity, flex staffing, all those things as best as we can. But I wouldn't say the performance picture is perfect. The specifics of the waiting time for elective gynae, I don't know, but I can definitely find that out quite quickly and get back to you on it.
Sorry, by second top in the city region, is what you mean, but not just Manchester.
In Greater Manchester, yes.
Yeah, cheers.
But as I say, nobody's doing brilliantly well.
No, Councillor Duffy.
Thank you very much, Stephen. I'm hesitant to ask the next question, but I'm going to anyway. Where does Brexit sit on your current risk register in terms of medicines, staffing, research, funding? Does it keep you awake at night? And what may or may not happen, and how's that managed internally?
Yeah, so it's not something I would have been personally involved in at MFT. To the extent that I have followed it, I don't think MFT is trying to do anything different than what's coming down from NHS England about the things that they would expect people to be doing. Certainly, I don't know of any initiatives that are around securing the pharmacy supply chain that the individual hospitals would be doing. I think that's all national action that's looking after those things. I think in terms of access to a supply chain of staff who you can recruit, it's quite worrying because we have got lots of European staff and they I'd say one of the things I think is worrying is you can put in place the rules that could make people who've got professions and can earn a lot of money come and work here. You can't stop people feeling like they're not terribly welcome, and that may be the worst effect is that the sense that coming to Manchester might be a nice thing to do gets lost. We are off to India again next month or the month after on an Indian recruitment drive, which we've done in the past, and that's been very successful as well. So we'll carry on doing that sort of thing. And that's not particularly a reaction to Brexit. It's just, I don't think they've done it for a couple of years.
Government's on us all to make people who come here feel welcome. Any other points on that point? Councillor Mrs. Brumar.
I always feel very guilty recruiting from Indian subcontinent or Africa or wherever, because these nurses are needed there. That's just always my feeling. I'd rather try and recruit Spanish nurses or whatever. Thank you.
There's countries that we're allowed to go to and countries we're not allowed to go to for that reason.
Okay, well, can we note the contents of that report then, please? And thanks, Stephen, very much, as always, for his time and sitting here with us so patiently. And Stephen, if you could get that extra information back to us, that would be super. Thank you. Moving on, item 10, which is the dementia-friendly dementia strategy report. Someone presenting this? Or has anyone anything to say to it, Sarah or Judith?
Eleanor's not here to present, but I can take any questions or take anything back for you.
I can as well.
Okay. Can I just make the point, please, that the last paragraph, well, obviously, you know, the fact that you welcome involvement with Health Scrutiny Committee is very good. I think the committee will decide what we call in. And obviously something like this will obviously appear, especially the age well strategy will appear in probably several agenda, future committee agenda. And obviously I think we will need a lot more detail, although I appreciate at this stage we're in the consultation phase and there's not a huge amount more that you can provide us other than what's in front of us. And I would just say that like mental health, parity of esteem, like dying well, making sure our communities in Trafford are dementia friendly is very, very important, I'm sure, to all the members of council, and it's very pleasing to see that there is a focus on this. Any points or questions that can be taken back from any members? Heather.
I repeat this at lots of meetings I go to, but I think that one of the pressing needs, particularly with the closure of a couple of nursing homes, is the fact that we must have something for people with challenging behaviour. It's a real problem trying to get people placed, and they're just as serving as anybody else in having good quality of care.
So I take that on board, Chair. So we can absolutely bring back what you want in terms of that. So we'll work with Alex in order to do that. We're developing the sort of action plan, which is looking at what's going to be in there, leads, etc. So obviously we'll put that in as well, and we'll take on board in terms of care homes and challenging behaviour. So we'll work with Alex, let us know what we need, and we will bring that back for you.
Any further points, or can we note that item? Super, and thank you again, guys, for making sure this is a very important piece of work that we do. Moving on to the additional information report, or the to follow report, item 11, which was to receive the latest reports from Health Watch Trafford. Everybody had sight of this. Super, as I always do at Chundra's length. Heather, can I just congratulate Health Watch on the quality of the stuff they present to us, the clarity of it, and the work that's gone into it. So we very much appreciate having a very high quality Health Watch organisation in Trafford. I think it quite clearly demonstrates that in terms of Ascot House and the information that's presented to us, that whilst the standard of care that relatives of patients and patients themselves clearly think is generally up to scratch, the concern seems to be around patient involvement and input into plans of care. So clearly this is very much something that we can pick up as a committee, both in the task and finish work that we're doing at the moment, and also in general. So this is very, very useful information. So thank you again, Heather. Any points on further points on item 11 and the Health Watch report? Councillor Taylor.
Again, yeah, a very, very comprehensive and well-researched piece of work. It presents the results, doesn't it? But there's not really any sort of key recommendations or anything like that at this juncture. Is there anything that you'd want to sort of add to that, really?
Yeah, I mean,
or what would you recommend we maybe do with this information?
In terms of Ascot House, I know that it's being reviewed in several different areas, and I just think that the feedback that we've had will just add to that rich mix. And I think the reason there are no specific recommendations really is that we know that this work is ongoing, and that this is just, I hope, will become an integral part of it, because what people feel about their experience is extremely important.
Yeah, thank you. Yeah.
Councillor Mrs. Brewer-Morris.
Thank you. Yeah, I do hope that it's actually picked up by the council, because I think it's really, really difficult for people. And sometimes people will go in a home, and if it's been newly decorated or it's got nice furniture, they equate that with good quality care, whereas the CQC might be there saying it's in need of improvement. And I think that, you know, we owe it to our population to provide them with good, honest, straightforward advice. And I think this is probably the first time this has been done in this way. And we've put a proposal to Greater Manchester that we actually have this as a whole Greater Manchester exercise to see across the 10 boroughs the variations that there are, because I think it will we'll all be able to learn lessons from it.
Sorry, Dan, you wanted to...
Absolutely welcome the reports. Well, obviously these are areas that we're asking Health Watch to go and look at, because we want to improve and learn, and it feeds really well into our improvement programme for resident nursing provision. We will be taking the reports, obviously, and having a look as a team as to how we would incorporate that into the learning going forward. The choice of care home we mentioned last time, didn't we? It is a very complex process and something that you only really think about when it is in front of you. And so we really welcome some of the thoughts and ideas, and the experience, understanding that experience is really important. We are very timely looking at information online and how we will get better information out to people so we can feed all that in. And I think probably from my point of view, I would like to jointly come back with some action planning that takes some of the learning from this into changes, really.
Thank you. Councillor Duffield, do you want to say something? Yeah, just an observation, Dan. I mean, obviously, as you know, Ascot House is in my ward, and just lately, since our visit, actually, I've had a couple of two separate instances where the front gate process, in terms of dealing with the community, has not been what I would expect. And I think I understand the manager has been off. And I think but it may be symptomatic of some of the things that have been identified in here. I really think it needs to be looked at as to what arrangements are made when Sue isn't there. So
absolutely, I'll take those issues up. I mean, again, on the Ascot report, we welcome there's some very, very positive feedback in there, but there are some areas where, you know, as one of the leaders here, that I read and think, well, I wouldn't want that for my mum. So we will pick up those individuals issues, because obviously there's a lot of quality work there, and it has just got a very, very good CQC rating back this week. However, but we always strive to improve. So if it doesn't work for one person, it's not working as we would want it to. And if there's any specific detail you'd like me to pick up, I'll pick it up with you.
Super. Well, if we can all note that report, and thanks as ever to Heather and Health Watch for their terrific work. Item 12, the Greater Manchester Health Scrutiny Committee, a verbal update from the Vice Chairman, Councillor Taylor.
Thank you. I'll just keep this brief. I went to my first GM Health Scrutiny meeting last Wednesday, and there were two key items on the agenda. One was presented, and this was led the work of Warren Heppolite, who is the GM Health and Social Care Partnership lead, working with voluntary and community and social enterprise sector across GM. And this is a whole strategic piece of work, and I actually received the slides back from that we were presented with and we talked around. So if the committee would like me to share those with you, I'm more than happy to do that, really. So this is all part of the Devo Mank health initiative, and it's about rebalancing social and the relationship between social and healthcare, really, and a recognition, I think, that statutory services cannot provide everything, and it's not always desirable that statutory services. And somebody who's a sort of a huge advocate of the NHS, who's always worked in the NHS, and is recognition sometimes that services are not always necessarily best placed in the statutory services, really. And in actual fact, we've got 300,000 volunteers across Greater Manchester and 15,000 registered organisations, and it's recognised it. And within Trafford, we're actually a smaller contributor overall, but we have almost 1,500, I should say, constituted groups in Trafford, offering a whole range of services to people to enhance their health and well-being, really, and sort of just discussing really how the sector can make an even greater contribution, really, to people's health and well-being, particularly around the areas of mental health, around cancer prevention and support, in the areas of smoking and alcohol management, and particularly in the area of social prescribing, really. So it was an update on that, and sort of looking at some of the successes, looking at sort of methodologies moving forward, really. And I think it might be useful to maybe explore how that's working within Trafford, really, and sort of and really sort of perhaps delve into what we actually have in our own communities and how they're sort of connected up, really. So that was. Do you want to respond to that, Sarah? Yeah.
Absolutely, sort of agree with everything that you've said and what Warren's done. And yesterday we had an afternoon with our local voluntary sector organisation to look at those about how we can actually work with the public sector and our voluntary sector differently. They're looking at a collective so that we can actually get more involved in terms of that and all the things you've just said. And one of, there's lots of things happening, obviously, but one of the things is that mental health model that we brought today. So that social prescribing in there.
It really ties in with what you've said.
We really need to do much more, but we're starting to tie in, and it be really a priority for us in terms of community assets and shift and our whole perception about sort of people owning their own health and well-being as well. So and we're meeting with Warren and meeting with Giles to sort of look further about what we can do. And one of the things we want to look at is our own workforce and maybe changing our lens about how we view the voluntary sector differently, and therefore how we work differently with our colleagues in the voluntary sector as well.
Absolutely, yeah.
Just to say that social prescribing is going across the board in the health and wellbeing, and I attended a conference at Manchester Cricket, at Lancashire Cricket Club for Greater Manchester, and the social prescribing that can be done through the voluntary sector is, some of it's amazing. The other thing is that we now have 2 voluntary sector representatives actually on the Health and Wellbeing Board, and I think that's a move to show how important that we think that the voluntary sector is in delivering some of the priorities of the borough.
Yeah, I agree. I mean, I think some of this has actually perhaps emerged out of the times that we find ourselves in. Sort of times of austerity. That not everything is. It's not possible, is it, to deliver everything within statutory services? But actually, out of necessity has come this whole sort of enriched kind of offer that has come from the voluntary and social enterprise sector. Really. Just a point to raise, really, something that they had observed within their work is that possibly fewer volunteers come from more deprived sectors of society, really, and sometimes volunteering is disproportionate to levels of deprivation, really. So more deprivation, fewer volunteers, which I thought was quite interesting because I represent Clifford Ward, which is probably one of the most vibrant community or has a very rich sort of history of volunteering and community activity, really. But I just thought it might be interesting to sort of scope out, what's going on kind of ward by ward, really, within our own communities, really. So yeah, I thought that was really, really informative. Yeah. And then the next item, there were just two big items on the agenda. It was initially led by, but it kind of opened into a wider discussion by Dr. Tracy Vell, who's a Manchester GP but leads for health innovation in Manchester, and she just updated us about the three key pieces of work that she's leading up, really. So sort of key strategies in primary care, really. She highlighted that there's a big workforce crisis in primary care, and fewer doctors now are actually wanting to go into general practice because of the sort of huge change in the way it is, and contractual issues and workload and things like that. So workforce strategies is something that they are addressing. But three areas of key concern in primary care reform, really, looking at the roles that we've discussed a lot of times, local care organisations and the collaborative working that we're doing, council, commissioning, healthcare, that we've talked about many times, really. Sort of more place-based service, again, that we've discussed, what is available from a whole range of statutory, voluntary, community social enterprise, really. That they've identified 68 key neighbourhoods, really, within Greater Manchester, and the focus is on sort of resilience within those neighbourhoods and development of quality services, and also how we can use, again, the digital services to enhance sort of patient experience, enhance recording of intervention. So those are the sort of key pieces. I'm just trying to summarise, really. I've made reams of notes, but particularly looking at those sort of key areas of work, really. She also alluded to the work of care navigators that we've talked about earlier as well. I think now we have this hugely broad offer of health and social care. It's often signposting people to the most appropriate services, and GPs are often used, aren't they, as those care navigators. But, now these specific care navigators are going to be based in GP practices, and, try and enable people to make the right choices for themselves, really, and be more instrumental in sort of determining their own health and social care, really. So, and some small scale things, really, that can sort of help to alleviate loneliness and offer services patients closer to their own home, really. So that's a whistle stop tour of a 2-hour meeting, but some really sort of key things. But I think it really ties in with the work that we're doing here and what's ongoing in Trafford, and a lot of the themes that we've explored in these meetings in recent months, really. Yeah.
The 68 key neighbourhoods of focus, did you happen to notice if any of them were in Trafford?
I did not have that information presented to me, and I haven't said.
The whole of Greater Manchester will be split into those 68 neighbourhoods.
Yeah, there will be them within Trafford.
No, it says it's the entire footprint, isn't it? It's split
It's
into
the whole of
68
GM, so
neighbourhoods.
there will be some of those neighbourhoods will be within Trafford. I suppose on average, 6.8 of them will be within Trafford. If you think there's 10 boroughs, aren't there?
Yeah, just
6 or
thinking
7 of them. I mean, we've got
possible.
our 4 localities, haven't we?
Yeah.
So I presume that's how the Trafford model.
I mean, we could make a fair guess, couldn't we? Which I suppose. Oh, so the 68 key neighbourhoods. It's not the whole of Greater Manchester.
Yes, it is.
Oh, right. So it's not specific small communities. 68 specific small communities identified. So for instance, the ones in Trafford will encompass the whole of Trafford. Or is it small communities within Trafford, for instance?
I think it's small. I think do we base it on our locality model?
Yeah,
presumably?
it's about 4. So it's about the sort of 30 to 50,000
Right.
in terms of a neighbourhood. So we'll have 4 around here.
See, I was misunderstanding you there. No, it's just curiosity. Any questions or points for Councillor Taylor? Super. Yeah, thank you for making detailed notes for us and getting back to it. It's great.
It's clear,
Yeah.
Try and get to the next one report back.
Super.
It's really interesting. Yeah.
Super. Thank you for that. Moving on then, item 12, which is that's what we've just done. And item 13, urgent business. I have none that I've been notified of. So can I finish just before we go? Oh, he's here. Can I wish Peter all the best? I think this is your last meeting with us, isn't it, before you move to pastures new? And just to say, you will be, I'm sure the whole council will miss you. And I think the fact that all our committees and our elections have been run so tightly and so well, I think is a testament to you and the way you manage everyone. And you will be very much missed, Peter, not least by this committee. So thank you very much for all your work. So can I thank all members for coming along on a very cold, dark January night, and I look forward to seeing you all in March. Thank you.